Well, I am here, and I just a few minutes ago I was sitting here in my office and preparing this webinar and thinking about how many of my colleagues will be sitting in front of the computer tonight to learn with me. And I just is I cannot. It's difficult for me to find the best way to say thank you. Um, I am a teacher, and regardless of how many degrees I have or how many things I did in my life, if it's something that I truly enjoy is to be teaching and learning. And doing these activities is really something that I feel extraordinarily happy. I can be actually doing this the whole day. This is what I really enjoy, and um and I really want to thank you for your time. I know it's late, depending if you are in the East Coast or Central Time or West Coast, depending of that. But if you are Central Time or East Standard Time, like me, it's about 7 p.m. So this is usually the time that you are finally, after a hard day, you are finally driving home and preparing to have dinner, and you decide that tonight you are going to learn about nitrous oxide. And so that means a lot for me, and I hope that you are going to learn. This is a wonderful webinar. Um, this is probably one of the webinars, and I have a different topics that I cover in my webinars, but this is probably the topic that I cover more often. And not just only I cover very often, but also I use nitrous oxide several times in my regular day. So not just only I'm going to give you a webinar about a wonderful tool that we have in dentistry, which especially you work with children, but you can also use nitrous oxide with adults. But this is not just only a wonderful tool, but something that I use in my daily life. So I want to welcome to this webinar everything that you want to know about the use of nitrous oxide in the practice of dentistry. That's me. I know, my camera is off, and uh, that's one of the requirements of this webinar, that my camera will be off the whole day. The whole day, the whole webinar. But that's me. I am a faculty at IU, Indiana University, and I spend about pretty much my whole time working at the Children's Hospital. And that's Riley Hospital for Children, which is the main children's hospital here in the state of Indiana. And very proud to work here every single day when I'm walking through the main door and I see all these little ones walking through the door. I feel extraordinarily, proud to be working here in Riley. I think so. If you work in a children's hospital, that's a different environment. I strongly believe that children's hospitals, they really make a difference in the families, and they make a difference, obviously, in the children. And so that's the place that I work, downtown Indianapolis. We provide care to children around the state, and even sometimes families who live outside the state of Indiana. They drive all the way downtown to find providers and to find physicians and dentists here at Riley. So because as I mentioned, the camera is off, so I will keep showing my picture a bunch of different times during my lecture, so you will remember. I will keep putting my picture, so now that picture is about maybe 10 years younger. I look quite different from that picture. So we are going to talk about nitrous oxide. Before we go and I start, just a couple of seconds just to mention that I know some of you are aware. If you are not aware, let me just introduce you to the textbook, McDonald and Avery, Dentistry for the Child and Adolescent. That's the textbook that the majority of pediatric dentists and many of the pediatric dentistry residency programs across the U.S. and even outside the borders of the U.S. is the main textbook in pediatric dentistry. And I'm very proud because the textbook was born here in our department. We published in 2021 the 11th edition, and I know there are several textbooks in pediatric dentistry outside, excellent books, but without any question, McDonald and Avery is at the top of the best textbooks in pediatric dentistry. And we are all the picture that you see here on the screen. This is all the faculty here from our institution. We are 5 faculty members working here at the hospital and 3 faculty members working at the dental school. This is one of the largest departments in pediatric dentistry in the country. We are 8 full-time faculty members working in the department. So these are the goals for tonight. I hope that you are not going to take a nap, and I'm looking at you because the first half of the webinar is about pharmacology. I'm sure you are not completely surprised about that, because if we are going to discuss nitrous oxide, if we are going to try to understand why nitrous oxide is a good tool that we have in our armamentarium to provide care to our patients, I strongly believe that we need to review the pharmacology. So we are going to spend some time talking about the pharmacology, the pharmacokinetics, and the pharmacodynamics of the nitrous oxide. So the first goal for tonight is understand the pharmacology basis of nitrous oxide. We are also going to learn the most critical indications. So we are going to learn when is exactly the perfect patient to use nitrous oxide. I'm going to spend some time reviewing that, and a lot of the information that I'm going to provide for that bullet point is coming from my experience using nitrous oxide day and night for the last 10 years or 12 years of my life. So I will kind of share with you my experience, and I fail, often. And pretty much the reason that I fail when I'm using nitrous oxide is because my patient is not a good candidate for using nitrous oxide. So the selection of the patient is, without any question, probably the most critical point when we are going to discuss the indications of the use of nitrous oxide. I know that you are sitting there and you want to really learn, and almost like a recipe, you want to, oh my God, this patient is perfect for nitrous oxide. I will tell you my experience, but at the end of the day, experience and you working in your office using nitrous oxide, failing, and that will happen to me often, is probably the best way or the best strategy to really understand the best indications of the use of nitrous oxide. As important as to learn the indications is to learn the contraindications. There are some patients that it's not a good idea to use nitrous oxide. We are going to discuss that in more detail. And then I have some tips that I don't have a particular section about tips. I think so the tips are coming around the whole lecture for the successful use of nitrous oxide in dentistry. That is how we translate what we are going to learn in the webinar to our clinic, to our patients. And the tips are pretty much coming from my experience, but they are also coming from the foundations of nitrous oxide. So in other words, we need to understand the pharmacology. If we understand the pharmacology of nitrous oxide, then we can understand the tips. So we can have a successful use of nitrous oxide in dentistry. As usually, if you want to have a copy of this presentation, you can send me an email at your convenience. You can email me. You can see the email is on the screen. And you can send me an email and I will share with you this PowerPoint. I also want to mention that this lecture is sponsored by Air Techniques. They have a pretty robust portfolio of different products, and we are going to discuss some of the products in this webinar. I just want to start with some facts. 89% of the dentists who provide care to pediatric patients, they use nitrous oxide. So I think so the majority of dentists who are working with kids use nitrous oxide. Some dentists are heavy users. Some they use nitrous oxide maybe a couple of times, but definitely if you work with children, you are more familiar with the use of nitrous oxide than if you work with adults. About 58% of the dentists in our country, in the US, they use nitrous oxide. And I know we have some participants from outside the US. And I know, coming originally from Latin America, I know that in other places of the world, the use of nitrous oxide is not as often as we use nitrous oxide here in the US. Here in the US, more than 650,000 dentists, hygienists, and dental assistants practice dentistry in the US. So there is no question that dental practitioners may be exposed to excessive levels of nitrous oxide. So we are going to learn, and this is one of the critical points, critical message of my webinar, the best practices when we are going to use nitrous oxide. And the best practices are engineering controls like scavenging mask, local ventilation, and a couple of more things to decrease the exposure to nitrous oxide. And so this is the agenda that I have for tonight. The introduction, we are going to look a little bit in the history of nitrous oxide, the pharmacokinetics, pharmacodynamics, a little bit of the side effects, practical recommendations, equipment, and then I have a last section about occupational health. So let's start with the introduction. And I just want you to stop for a couple of seconds, look at the slide, and then you are going to see that I have a couple of happy face. That's something new that I'm doing in my webinars. And maybe you are wondering, what is the meaning of the happy face? Well, the meaning of happy face is something that I really want you to remember. Well, not to remember, at least to understand. It's kind of, rather than, sometimes the slides are full of information, and the use of my happy face, the yellow happy face, is kind of to narrow out of the entire slide what, in my opinion, is something that is remarkable important. So you will see the happy face over and over and over across the entire PowerPoint. So nitrous oxide is a gas at the room temperature, is colorless, is non-flammable. However, together with oxygen, they will support combustion and slightly sweet odor and taste. Now, we are going to review this with more detail in a few minutes, but just an introduction. Nitrous oxide induces opioid peptide release in the brain. So basically, when we are using nitrous oxide, we are actually pushing the brain to release opioids, leading to activation of descending noradrenergic neurons. And then that is going to take to a modulation of the nociceptive process in the spinal cord. We are going to review that in more details in a few slides. Nitrous oxide, major portion is major action is an analgesic effect. And that analgesic effect comes from the interaction with the opioid receptors and a possible interaction with the beta endorphin release. Originally, nitrous oxide was synthesized by Priestley in 1776. The nitrous oxide analgesic action was first described in 1800. And a dentist, Dr. Wells, was the first person to demonstrate the use of nitrous oxide for pain relief in 1844. So nitrous had been around us for a long time. Nitrous oxide is a gas anesthetic agent that is not sufficiently potent to produce surgical anesthesia as a single agent. Early studies, and you can see that we have an early phase here, that means that is probably the most important statement of this slide. Early studies evaluating the potency in comparison to opioids analgesics, they found that 30% of nitrous oxide is about 10 to 15 milligrams of morphine. So let's go a little bit about the anesthetic properties of nitrous oxide. There is a low blood, or nitrous oxide has a low blood solubility, and that results in a rapid induction and awakening. So pretty quick, nitrous oxide will go into the bloodstream. As I mentioned before, the minimal alveolar concentration, we call that the MAC, of nitrous oxide is about 105%. That means that it's a pretty weak inhaler anesthetic and is incapable to full anesthesia by itself. So nitrous oxide is used in anesthesia to achieve more rapid induction and recovery because the MAC of nitrous oxide is additive with other slower acting anesthetics. There is a minor depression in cardiac output and a slight increase in peripheral resistance with really little or no change in the blood pressure when we are using nitrous oxide, and that's my happy face here. I just tell you a few slides about the history. I don't think so it's critical to spend here 20 minutes, just a few minutes here. So we can argue that probably the oldest anesthetic in human history is nitrous oxide. This is a little bit of the dates in the history of nitrous oxide. It was discovered in 1772, And then in 1863, nitrous oxide was reintroduced by Dr. Colton for dental extractions. I mentioned before that Dr. Wells was the first one who, actually, he was a dentist, the first one who used nitrous oxide as an analgesic. In 1824, that's in the middle of the slide, was the first laughing gas parties. So I can imagine a bunch of people just connecting with nitrous oxide, and I can imagine how many of these probably die when they start to use pretty high concentration of nitrous oxides for a long time. This is the Heydrink anesthetic machine, who was designed in 1912, not too different from the anesthesia machines or the machines that we use nitrous oxide that we are going to discuss later today. Okay, here we go. Let's go a little bit about the pharmacokinetics. So I hope that you are still there. I will briefly, I promise, I will try to keep this as simple as I can. I'm going to discuss the absorption, the distribution, the metabolism, and the elimination of nitrous oxide. So we'll go with pharmacokinetics first. So how it does work, how nitrous oxide works. So 3 bullet points. Out of the 3 bullet points, there is one with a happy face. That's probably the most important. So I'm going to start with that one. So nitrous oxide promotes the release of endogenous opioid neurotransmitters. That means that when we are using nitrous oxide, we are going to push the brain to release opioids that we produce in our own bodies. Also, nitrous oxide produces inhibition of the N-methyl diaspartate receptors, of the excitatory glutamate receptors. And also, finally, nitrous oxide stimulates the alpha aminobutyric acid or GABA receptors and the alpha amino 3 hydroxyl 5-methyl 4 isoacyl propionate receptors. So in summary, probably the most critical information of this slide, if somebody asks you someday how nitrous oxide works, probably the most important is the release of endogenous opioid neurotransmitters. A little bit of the physical and chemical properties, as I mentioned before, the MAC is over 105, it's over 100%, so you cannot really cause completely anesthesia just using nitrous oxide. It's colorless, mild odor and taste, is very poorly soluble in blood. The blood gas coefficient is about 0.47, no flammable. However, as I mentioned before, with the presence of oxygen, will support combustion, is found in liquid and gas equilibrium in pressurized cylinders, and the cylinder pressure, 750 psi, is unaltered until more than 3/4 of the content is released. A little bit more about the pharmacokinetics of nitrous oxide. Inhaling nitrous oxide may produce the second gas effect. Nitrous oxide diffuses more rapidly across the alveolar basement membrane than does nitrogen. The rapid exit of nitrous oxide from the alveoli causes remaining gases to be concentrated. That's the reason that when the administration of nitrous oxide stops, nitrous oxide enters into the alveoli far more quickly than nitrogen leaves, causing dilution of the gaseous contents of the alveolus, and that's what we call diffusion hypoxia. One of the ways to avoid, and we are going to talk in a few minutes a little bit more about diffusion hypoxia, is not a good practice to stop suddenly the nitrous oxide. We stop this nitrous oxide, but we need to leave the patient breathing 100% oxygen for a little bit to try to prevent the diffusion hypoxia. We are going to go over this in a few more minutes. So this result, the diffusion hypoxia, results in the dilution of the oxygen within the alveoli of the patient breathing air and may cause diffusion hypoxia. Nitrous oxide is eliminated unchanged from the body almost entirely through the lungs. Nitrous oxide has activity at several types of receptors. The main receptors that nitrous oxide is going to work is the N-methyl diaspartate glutamate receptors, which are in your brain, and also the stimulatory activity of the dopaminergic, adrenergic, and opioid receptors. Nitrous oxide is the weakest of all the inhalation agents with a minimum alveolar concentration, as I mentioned before, of 105. Remember, MAC, or the minimum alveolar concentration, is a measure of the potency of the anesthetic. That's the concentration required to produce immobility in 50% of patients upon surgical skin incision. So that means that if we want to cause 50% of immobility, we will need to use 105 concentration of nitrous oxide, and obviously we don't do is extraordinarily higher. So it's a pretty weak inhalation agents comparing with sevoflurane or the other inhalation agents. The nitrous oxide concentration between 30 to 50%, which is what we are going to use in dentistry, will produce a relaxed, somnolent, sometimes euphoric patients. That's what we call the paradox reaction, who may appear dissociated and easily susceptible to suggestions. So if we keep the concentration of nitrous oxide something in between 30 to 50%, which is 0.3 to 0.5 of the minimum alveolar concentration, the consequence of that, the release of the endogenous endorphins, the consequence is a relaxed, a little bit sleepy patient who may appear dissociated, kind of a little bit disoriented, and very easily susceptible of suggestions. And that is something that I use all the time when I'm using nitrous oxide. When I'm using nitrous oxide, and we are going to talk about the technique later, but please remember that the patient, when you are using nitrous oxide, the patient is pretty easy susceptible to suggestions, especially the young kids. So when I'm using the nitrous oxide, one of my little tips is I start to tell the patient a story. And I tell the patient always the same story, trying to use distraction. Distraction is one of the more powerful non-pharmacological techniques that we use in dentistry. So before I start the injection or before I'm going to do, I use distraction. But if on the top of the distraction, I use nitrous oxide, it works perfect. Because the patient, when you are using nitrous oxide, the patient is very susceptible to suggestions. And the suggestions are part of the whole distractions. Now, if we go higher, that 50% using nitrous oxide, that's when we are going to increase the likelihood of starting to see some side effects, like nausea. Nitrous oxide has a low blood glass solubility, and that means that the uptake and the elimination of the nitrous oxide by the body is pretty quick. This is a very positive pharmacokinetic profile, and that's augmented in children by the higher minute ventilation ratio and higher cardiac output. So in other words, in kids, the uptake and the elimination of nitrous oxide is pretty quick. Nitrous oxide reaches equilibrium in the brain within a few minutes after we start to use it. The elimination of nitrous oxide is exhaled unchanged. Only a super small fraction of nitrous oxide is metabolized in the GI tract, less than 1%. So pretty much 100% of the nitrous oxide is eliminated through the respiration without any change. Okay, so that's the pharmacokinetics. I know, sometimes it's a challenge. Let's go a little bit more into the pharmacodynamics. And then, believe me, after the pharmacodynamics, we will go into the real. That's what you are looking for. But it's important to remember the pharmacology of nitrous oxide. So let's start with the cardiovascular effects. The use of nitrous oxide in healthy people, healthy kids, healthy adults, is not usually coming with a meaningful changes in the heart rate or the blood pressure. So you are not going really, if you use nitrous oxide and you use diligent, you use 30 to 50%, you are not really going to see an increase in the heart rate, and you are not going to see an increase in the blood pressure. Now, the pulmonary vascular resistance is different. The pulmonary vascular resistance is increased by nitrous oxide because the constriction of the pulmonary vascular smooth muscle. That increased the right atrial pressure. So, generally speaking, we don't see this a lot in pediatric dentistry, but if you work with adults, and I'm sure you work with adults, some of you work with adults. If you work with adults, it's probably not a good idea to use nitrous oxide in patients with pulmonary hypertension. And I just explained why, because the nitrous oxide is going to cause some constriction of the pulmonary vascular smooth muscle, and that can increase the right atrial pressure, and then secondary, that can increase the pulmonary hypertension. Now in pediatric dentistry, as I mentioned before, is extraordinarily rare to have a patient with pulmonary hypertension. So in conclusion of this slide, no changes in the heart rate, no changes in the blood pressure, and there is an increase in the pulmonary vascular resistance. So nitrous oxide, let's look at the respiratory system. Nitrous oxide causes a decrease in the tildal volume. That's the amount of air that moves in and out by the lungs, and increasing the respiratory rate. So when you are using nitrous oxide, there is a decrease in the volume of air that your lungs are moving in and out. And as a compensatory mechanism, there is a slight increase in the respiratory rate. Why? If you want to know, because there is a activation in the pulmonary stretch receptors in your brain by nitrous oxide. At the end of the day, the minute ventilation is maintained. Yes, there is a decrease in the tidal volume, but that decrease is actually compensated by an increase. And when I mention increase, it's not an amazing increase, it's just a little bit. And that increase in the respiratory rate will keep the minute ventilation unaffected. So the reduction in the ventilatory response to hypoxia and hypercapnia could be also a potential consequence of the use of nitrous oxide. How about in the central nervous system? Nitrous oxide increases the cerebral blood flow, the cerebral metabolism, and the intracranial blood pressure. When we look at the neuromuscular system, nitrous oxide has the potential to increase the skeletal muscle activity. Now let's look with detail into the analgesic action. We talked before about that, but it's important to kind of look for the pharmacodynamic perspective, a little bit more about the analgesic action. So nitrous oxide has analgesic actions through to be mediated by activation of opioid receptors in the gray part of the midbrain. This leads to modulation of nociceptive pathways through the release of norepinephrine and activation of alpha-2 adrenoreceptors in the dorsal horn of the spinal cord. Part of the pharmacodynamics is important to review the adverse effects of nitrous oxide. If this webinar is about the use of nitrous oxide, which is a wonderful tool, we also need to learn what is the adverse effects. I already mentioned something related with the concentration. If we keep the concentration of nitrous oxide between 35 and 45%, then the likelihood that we are going to see the adverse effects of nitrous oxide are less than if we keep working with higher concentrations. Probably the most well-known adverse effect of nitrous oxide that happened several times to me, and I'm sure to you, is the postoperative nausea and vomiting. We really don't know exactly why that happens. However, changes in the middle ear pressure, bowel distension, and activation of the dopaminergic neurons may all be involved in the postoperative nausea and vomiting, which is about 1 to 10% of the patient, which is significant. Especially we look more to 10% of the patient. That means for every 10 patients that I use nitrous oxide, maybe 1 will have some significant nausea and vomiting. But I will tell you in a few minutes how we can decrease that. Now, air-filled spaces, this is related with the diffusion hypoxia that I mentioned before. So the relative solubility of nitrous oxide and nitrogen cause rapid expansion of the nitrogen-containing spaces. That's what we call the diffusion hypoxia that happens in your lungs. Diffusion hypoxia can cause headache, disorientation, and nausea. That's the reason that it's a good idea, as soon as you finish to provide nitrous oxide to the patient, to give the patient a couple of minutes of 100% nitrous oxide. 100% oxygen. So diffusion hypoxia, at least in theory, when nitrous oxide administration is stopped, large quantities of nitrous oxide may diffuse from the blood into the alveoli and dilute the oxygen. That's the meaning of diffusion hypoxia. So as soon as I stop the nitrous, it's a good idea to provide extra 100% concentration oxygen. Now, there are a couple of studies that I really don't want to go into many details. Again, if you want to get this presentation, I told you my email, but there are a couple of studies who look at the oxygen saturation in diffusion hypoxia in children following the administration of nitrous oxide. This is one of the articles. It was published in 1993. They look at the oxygen saturation of arterial blood in children after stopping nitrous oxide sedation for dental procedures. Then they have two options. They place the patient in 100% oxygen for 5 minutes, or the patient just breathes room air for 5 minutes and they look at the oxygen saturation. The fluctuation of the oxygen saturation between these two groups was statistically significant. So meaning that the patients who just breathe room air for 5 minutes, they have a lower oxygen saturation. However, that difference was less than 1%. So it was statistically significant, but less than 1%. So allowing the children to breathe room air immediately after cessation of nitrous oxide inhalation didn't decrease the oxygen saturation below clinically acceptable levels. That was the conclusion of this article. I have one more. This is a clinical study of diffusion hypoxia after nitrous oxide analgesia. Again, they measure the arterial oxygen saturation in 104 healthy adults dental patients who were administered nitrous oxide oxygen and analgesia, and they didn't receive post-cessation oxygen. The pre-treatment saturation levels, as determined by pulse oximetry, was between 93 to 100. When the nitrous oxide administration stopped, the saturation levels were from 95 to 100%. So again, the mean saturation dropped about 2% over the next 4 minutes and then stabilized. No patient has a post-treatment oxygen saturation less than 92%. So what is the Yepes conclusion here? If you are awake, I personally prefer, as soon as I stop the nitrous oxide, to place my patient for about a minute, maybe 2 minutes with 100% oxygen. I am decreasing the likelihood of diffusion hypoxia, and I may well decrease the possibility that the patient will have some headache and some nausea and vomit after I use nitrous oxide. So honestly, even the articles, they don't really support the idea that if you stop suddenly the nitrous oxide, you are going to cause a dramatic decrease in the oxygen saturation. They don't support that. Clearly, I prefer to do that. So the diffusion hypoxia can be eliminated by administration of 100% oxygen following nitrous oxide administration. And then a happy face here. The importance is really in scavenging expired nitrous oxide and reducing nitrous oxide pollution. Also important to raise the chair and allow the patient to posturally recalibrate. So going the patient to the normal position slowly. What else about the adverse effects of nitrous oxide? How about the air-field spaces, like the middle ear pressure can increase? So patients with acute otitis, they are not really good candidates for the use of nitrous oxide, because if the middle ear pressure will increase, then the patient probably will have an exacerbation of the pain. How about toxicity of nitrous oxide? Exposure to dental personnel to high ambient air levels of nitrous oxide can cause some neurotoxicity, sexual and reproductive issues, hepatotoxicity, and renal dysfunction. So we are going to learn at the end of the webinar what we can do in a dental office to try and to be effective in decreasing the amount of nitrous oxide who is free in the room. So nitrous oxide increases the volume of any closed air pocket in the body. Nausea and vomiting are the ones that I will point at, probably the most common side effects. And nausea and vomiting when we use nitrous oxide are related with 4 things. Listen to this. Longer duration, so when we use nitrous oxide for a long time, fluctuations in concentration, lack of titration, and increase in the concentration. So it's not a good idea to start 35, then 30, then 25, then 40, then 45. So we need to learn to titrate it, and we are going to have a review of that in a few minutes. And also, if we work with higher concentration of nitrous oxide, more likely we are going to see these adverse effects. How about vitamin B12 inactivation by nitrous oxide? That's a very interesting topic about the use of nitrous oxide. So nitrous oxide may cause irreversible inactivation of vitamin B12. And what is the point? Irreversible inactivation. So that's a big deal? Well, maybe it's a big deal, Because what happened is vitamin B12 is a cofactor in the folate and methionine cycles. So in patients with methionine or MTHFR deficiency, which is an autosomal recessive, the whole name is methylene tetrahydrofolate reductase deficiency, which is MTHFR deficiency. It's a gene mutation. This MTHFR is responsible for folate metabolism and homocysteine regulation. So nitrous oxide inhibits the transformation of homocysteine to methionine and subsequently leads to an accumulation of unconverted homocysteine in affected children. So it's not a good idea to use nitrous oxide in patients with methylene tetrahydrofolate reductase deficiencies. Because in these patients, we actually can inhibit the transformation of homocysteine and methionine, and we are going to have an accumulation of unconverted homocysteine in affected children. And homocysteine levels can also stem from deficiencies in vitamin B12, folic acid, and vitamin B6. So in this complicated slide, which it's not my idea that we are going to review the whole thing, but nitrous oxide inactivates the methionine synthetase, and in patients with this syndrome could be a big issue. So it's not a good idea to use nitrous oxide in patients with the methylene tetrahydrofolate reductase deficiency. How often we see patients like this in the practice? Not very often. Let's talk about more practical points. Okay, that's the perfect kind of break of my webinar. We learned some pharmacokinetics, some pharmacodynamics, and a bunch of information of nitrous oxide, how it works. We learned the receptors. We learned a couple of other issues, adverse events when we use nitrous oxide. Some of the adverse events, probably nausea is the most common. I just kind of have a parenthesis here, or kind of a middle of my presentation, and let's move more about practical issues about nitrous oxide. It's not my intention to repeat what I just explained. However, repetition is always good. It's my intention to use this second part of the webinar to really kind of transfer my experience and my clinical experience with using nitrous oxide for you, so you can also transfer that to your patients. So let me start with the general indications. Anxious patients, that's a clear one. Long procedures, however, in pediatric dentistry, we don't have long procedures. But again, you can use nitrous oxide with adults. I'm sorry, I clicked the wrong place. Painful procedures. I was telling today my residents here that I know I'm going to say something that is super crazy, but that's okay. The webinar is sponsored by Air Techniques. They are not going to kill me to say this. Sometimes just using nitrous oxide, listen to this, just using nitrous oxide, I can prep a tooth for a crown. In some patients, I don't need to use anesthetics. I just using nitrous oxide, titrating the nitrous oxide in the correct way, I can open the interproximal space without using lidocaine or without using articaine. It is absolutely amazing how, when we are using nitrous oxide correctly, how we can cancel that painful perception. And remember, I mentioned that the patient are more susceptible for kind of distraction. So I was today telling my residents here in my program that I can prep a tooth for a crown without using a drop of lidocaine in a young kid, just using correctly nitrous oxide. So simple restorative needs, and you do the same that I do. Very often we don't use lidocaine. We can use just nitrous oxide. Nitrous oxide is also a good helper for patients with a strong gag reflex. And more often than you can imagine in my office, when I'm going to take radiographs, sometimes some patients, and you know this, they have a strong gag reflex. I can use nitrous oxide to try to decrease that and be able to take radiographs. Why we want to use nitrous oxide? We want to decrease or eliminate anxiety. We want to decrease untoward movement and reaction to dental treatment. We want to increase the communication in the patient cooperation. We want to increase the pain reaction threshold. We want to increase that. We want to increase the tolerance for longer appointments. Again, maybe more adult dentistry. We want to decrease the gag reflex. And we want to potentiate the effects of other sedatives when we are using or when we are doing oral sedations with maybe benzodiazepines like midazolam. We want to potentiate the effect of the benzodiazepines when we use nitrous oxide. Now, like everything in life, not everything is perfect. There are some disadvantages of the use of nitrous oxide. Number one, it's not very potent. We know that from the front. It's highly dependent on the psychological reassurance. So that means that we need to explain to the patient, we need to tell the patient that nitrous oxide is actually a good helper, but it's not going to put the patient to sleep. Sometimes one of the disadvantages of using the nitrous oxide is the interference of the nasal hood with the injection to the anterior maxillary region. So that's the reason, and I will show you some pictures in a few minutes about different nasal hoods. So we want to try to use the one who is less prominent, because the ones who are really prominent, they are going to interfere with the injection. The patient must be able to breathe through the nose, obviously, and the nitrous oxide pollution and potential occupational exposure hazards. That's one of the disadvantages. So let me go with the indications. And this is repetition of the repetitions. Fearful, anxious, some patients with special healthcare needs, patient with a marked gag reflex, and a cooperative child undergoing a lengthy procedures. Critical slide. Contraindications. Some chronic obstructive pulmonary disease, we already mentioned that. Patients with current respiratory tract infections, especially upper respiratory tract infections, because if the patient is not able to breathe through the nose, we cannot use nitrous. Patients who are having recent or current middle ear infections, severe emotional disturbance, you cannot use nitrous oxide in a patient who is jumping around the chair. That's a basic principle. The patient that we decide to use nitrous oxide, listen this, my friends, need to be a patient who understands that the success of the nitrous oxide is to keep the nasal hood around the nose. Because if the patient is not going to be in the same page with you, if this is a 2-year-old, the 2-year-old, is almost wasting time and increasing the concentration of nitrous oxide in the environment, because a 2-year-old is not going to keep the nasal hood around the nose. The first trimester of pregnancy, and we are going to talk about occupational at the end of the webinar. There is not clearly, it's a contraindication to use nitrous. Patients who are having cancer therapy with bleomycin sulfate, there is a very complex reason why, but if you have a patient who is having chemotherapy with bleomycin, it's not a good idea to use nitrous oxide. As I mentioned before, patients with tetrahydrofolate reductase deficiency is not a good idea to use nitrous oxide. And kind of the same reason, patients with vitamin B12 deficiency is probably not a good idea to use nitrous oxide. Patients with a severe psychiatric imbalance. I have a happy face here. Patients who are precooperative, it's not a good idea to use nitrous oxide. So if the patient is not able to keep the nasal hood around the nose, forget about it. We cannot use nitrous oxide. And patients who are mouth breathers, they are not really good idea to use that. Okay, I got it. Now let's talk about the best technique for nitrous oxide inhalation. So the technique for nitrous oxide administration, this is my general points. 2 happy faces. Number 1, the use of scavenging systems that remove the nitrous oxide during patient exhalation is critical. That's probably the best way to decrease the amount of nitrous oxide around the environment. Ensure that exhaust systems adequately vent scavenger air and gases outside the building. Implement a careful, regular inspection and maintenance of the systems. Selection criteria is what we discussed. Contraindications. This is critical. Happy face. Select a properly fitted mask size for each patient. So you work with children, make sure that you use a nasal hood for children. If you are working with adults, you use a nasal hood for adults. The next is also a happy face. Even if I don't have a happy face, there is a happy face. Titrate the concentration of nitrous oxide. What is the meaning of that? That's really what kind of pays your time coming to my webinar. When I'm using the nitrous oxide, make sure that I explain to the patient that the patient is aware how critical it is to keep the nasal hood around the nose. Then I explain a little bit how the patient is going to feel. I like to tell the patient that a little bit sleepy, and then I start slow to open the concentration of nitrous oxide. It's not a good practice to jump into 45. The perfect scenario is you go 10% nitrous oxide, 15%, maybe 25%, and you wait at least 1 minute, 1 minute and a half in between the different concentrations. I cannot tell you enough how critical it is to titrate the concentration of nitrous oxide. I personally, my dental assistants, they are fully aware because they take a course with me, that my dental assistants, they are fully aware how critical it is to go slow into the concentration of nitrous oxide. That will decrease the chances that the patient will have vomit and nausea. But more important than that, when you titrate the concentration of nitrous oxide, the patient slowly will be a good helper. The patient almost will tell you, Dr. J, I go by Dr. J, I'm ready for you. Also, you need to encourage the patient to minimize as much as you can talking and mouth breathing. So I tell the patients, you have a good deep breath using your nose. I explained to the patient before, we are going to try to keep talking as minimum as we can. I like to use rubber dam, and the rubber dam is a good helper when I use nitrous oxide. And then 100% oxygen at the end of the procedure. The nitrous oxide must be administered only by proper licensed individuals. A flow rate of about 5 to 6 liters. We start with introduction of 100% oxygen for about 1 to 2 minutes. And then we go with the titration of nitrous oxide in 10% intervals. And we go no higher than 50%. In fact, I probably don't go higher than 45%. We need to pay attention to the scavenging vacuum. We need to have a good vacuum system. And we need to be sure that it's not too strong. We monitor the response to the patient to the commands. We have a clinical observation. And obviously, we need to have a documentation. We have an informed consent of the use of the nitrous oxide. Practical effects of the use of nitrous oxide, the body will feel a little bit warm. I explained to the patients before, sometimes you can have some tingling of the hands, sometimes auditory effects, and in a small number of patients, the reaction to nitrous oxide is the opposite that we are looking for. Some patients will have euphoria. That doesn't happen often to me, but once in a while, I have a patient who will be completely on the other side. May aid with local anesthetics. Patient is more still and doesn't interpret pressure and vibration as pain. In some patients, we need to have a med consultation. And remember the contraindication that I mentioned before, patient with severe COPD, congestive heart failure, sickle cell disease. It's not a good idea to use nitrous oxide in patients with acute otitis, patient with a recent tympanic membrane graft, or patient with an acute severe head injury. I think so it's common sense. All these are common sense to have either not use nitrous oxide or have a consultation with a physician. To finish, let's go and briefly go over the equipment. I like to have the patient with clear glasses or protecting eyes. The patient must be continually observed with inhalation. Minimal sedation is administered. I use with my patients monitoring of oxygen arterial saturation. I do that, especially after COVID. I decide to buy a bunch of all these oxygen saturation monitors. So I have a bunch of, I like to have that in my patients. It's not mandatory, but I like to do that. There is not really big changes in the blood pressure, heart rate before and after. So I don't check heart rate and blood pressure before and after the procedures. And I don't do capnography when I'm doing nitrous oxide. Capnography, checking the concentration of CO2. I do capnography when I'm doing sedations with benzodiazepines, but if I'm just using nitrous oxide, I don't use capnography. The inhalation equipment must have the capacity of delivering 100% and never less than 30% of oxygen. Remember, the oxygen that we breathe in the room is about 21 to 22%. So the idea is the equipment that you are using never will deliver less than 30% of oxygen. The inhalation equipment must have a safe fail system that is checked and calibrated regularly. And this is important, the system components, we need to have a reservoir bag, which is the place that the gases will mix. We need to have a proper scavenging system to minimize room air contamination and occupational risk. The usual equipment includes a nitrous oxide and oxygen delivery system. We have the gas mixing bag and then the nasal hood. I'm not going to stop here in detail because I think so you are familiar with the system in general. I just want to put a little bit more attention in the nasal hoods and the delivery systems in a couple of more slides. So we need to have some engineering controls that decreases the workplace exposure to nitrous oxide and increase the patient exposure to nitrous oxide, which is what we wanted. We don't want to have any leaks. We need to have the capacity of delivering 100% oxygen. We need to have a fail-safe system, and we need to have absolutely a scavenging system to decrease the nitrous oxide who is going into the environment. So this is the equipment. This is the scavenging system, basically 5 components: the gas collection assembly, the transfer tubing, the interface, the gas disposal assembling tubing, and the gas disposal assembling. We need to have an active scavenging system which is going to collect and remove excess gases to prevent them from being vented back into the room, which is probably the most critical step in decreasing the trace gas concentrations. We need to have the system active connected to a high volume vacuum system. This is an important slide. And I'm going to use particularly the FlowStar double nasal hood from Air Techniques, which is a good one, and I will going to tell you why. That's a double hood tubing scavenging system. What I mean with the double hood is inside the hood is soft and it's very comfortable, and that produces a tight seal with the patient nose. And the outside of the hood minimize the excess of nitrous oxide leakage into the treatment room. So ideally, we need to use a double nasal hood because we are maximizing the amount of nitrous oxide who is going into my patients, and we are minimizing as much as we can the leakage of nitrous oxide into the treatment room. This can be a single-use nasal hoods or auto-calibrable, so you can, depending on what is your preference. So this is the one that you see here in the picture, is the FlowStar double nasal hood, and I just explained why it's so critical to have the double nasal hood into the nitrous oxide system. We need to have the emergency oxygen requirements, which is the positive pressure oxygen delivery system, 15-liter medium flow recommended when using a back valve mask to deliver positive pressure of oxygen. And we need to be capable of giving to the patient more than 95% of oxygen at 10 liters a minute for at least an hour. So that's the emergency equipment that we need to have in a dental office for in case that we have emergency. The nasal hood is part of the equipment, is critical. That's the reason that I had the happy face here. You can see a bunch of different nasal hoods, and remember, as big as the nasal hood, sometimes that could be a problem when we are working in the front of the maxilla. This is the one, the double nasal hood that I mentioned before from the FlowStar from Air Techniques. It's soft, it's very flexible. This is the one that I use in my office. The inner of the nasal hood will have a perfect seal. It's an oval design for the exhalation valve. And also one of the good advantages is the lower profile. is significantly different from other systems who are available in the market. And this is the double nasal hood. The outer and the inside will help to maximize the amount of nitrous oxide going into my patient and minimize the amount of nitrous oxide who is going into the environment. A little bit more closer, this is the double nasal hood. That's the double hood design, minimizes the ambient nitrous oxide into the operatory. There is also, this is the front view, there is an oval exhalation valve that you can see there that direct exhale the gases to the built-in scavenger through the flow channels, and that increases the efficiency. There is a universal feed with other double tubing scavenging system. And one of the, probably the big reasons that I love this system is patient comfort. It's soft and it's easy for adapt the nasal hood to the patient nose. It comes in pediatric and adult sizes. This is soft, flexible, better seals, oval design. This is a different view and lower profile. Also the N-tilde CO2 adapter. I mentioned I don't do capnography when I'm just using nitrous oxide, but also I do oral sedations with benzodiazepines and other medications. When I do that, I use the N-tilde CO2 adapter for the capnography. And we can adapt that. You can see here in the picture, the double nasal hood N-tilde CO2 adapter is to be used during the delivery of nitrous oxide and oxygen. In patients, I use that particular when I'm doing sedation, and that is connected to my capnography device. That is going to measure the exhalation of CO2. And remember, that's the best way to monitor if the patient is breathing or not. So that's the connection. That's how we can connect the N-tilde CO2 adapter to the double nasal hood N-tilde CO2. And you can see how we can connect that. And then we can connect the capnography into the device. We are almost done, but before I conclude and I have some questions, I hope that you enjoyed this webinar. I know, only 55 minutes is usually not enough time, but I guess in even 55 minutes, I think it's probably enough time for you to get a little bit about how it works, the pharmacodynamics, the pharmacokinetics, the indications, the contraindication, the side effects, the vomit, titrate, the concentration, and the equipment. I think it's just enough time to at least get a general information. Remember, if you want to have my PowerPoint, you just need to send me an email. Believe me, I share my PowerPoints. I know some people will say, oh, he never. I always share my PowerPoints. J, F as in Frank, Y, E, P as in Peter, ES 1970 at yahoo.com. And if you send me an email and you say hello, I will share my PowerPoint. Almost done. But before we conclude, let's review the workplace safety information from OSHA, which is the Office of Occupational Safety here in the US, and the use of nitrous oxide in the dental office. So definitely, there are some animal studies that show adverse reproductive effects in patients who are constantly exposed, or animals, who are exposed for a long time to nitrous oxide. Per guidelines of the American Academy of Pediatric Dentistry, long-term exposure to nitrous oxide used as a general anesthetic has been linked to bone marrow suppression and reproductive system disturbance. That's the reason that we need to use an effective scavenging system. We need to have a pretty good vacuum. Probably the best vacuums in the market are the air techniques. So that's what I have in my office, and I always make sure that I'm using the scavenging systems, so I'm minimizing as much as I can the release of nitrous oxide into the environment, into the operatory. How about pregnancy in nitrous oxide? It's not wise to use nitrous oxide in pregnant patients. The animal studies show that could be a potential reproductive effects and also some problems with the baby. General workplace controls, when we are using nitrous oxide, limiting conversations with the patients, effective ventilations, effective gas scavenging systems, and proper maintenance. We need to have occupational exposure limits. OSHA doesn't currently have an exposure limit standard for nitrous oxide. The general guideline is to minimize the release of nitrous oxide into the environment. We don't use nitrous oxide batch monitors. This is the last slide. This is the best practice according to a OSHA survey. What we found and what employers or employees should do. I'm not going to read this because we are almost out of time, but I just want to take one. For example, 51% of the respondents to this survey with adult patients and 47% of respondents with pediatric patients, they don't check nitrous oxide equipments for leaks. That surprised me. Almost half of the users, they don't do that. So what are we supposed to do? Prior to the first use each day and every time a gas cylinder is changed, we need to test connection for leaks using a soap solution. So I don't do that daily, but as much as I can, I need to make sure that I don't have any leaks. To the survey, 60% of the respondents with adult patients and 40% of the respondents with pediatric patients started nitrous oxide gas flow before nasal mask was placed into the patient. We can't believe that. So what we're supposed to do is start nitrous oxide gas flow after the nasal mask is secure placed over the patient nose to minimize nitrous oxide exposure. 10% of the respondents with adult patients and 8% of the respondents with pediatric patients didn't turn the nitrous oxide gas flow before turning off oxygen flow to the patient. What employees should do, turn off nitrous oxide gas flow before turning off oxygen flow to the patient to minimize nitrous oxide exposure. Okay. That's my final remarks. Let me look at some questions. Can you share your email address? I just did that. Did you talk about other topics? Well, what documentation is needed for maintaining nitrous oxide systems, state and federal regulated laws? I think so you will need to check your own state because each state will have different regulations about that. Type your email. I will say my email again. JF, F as in Frank, Y, E, P as in Peter, ES, 1970 at yahoo.com. JF, YEP. Okay. They just put it there. Okay. Well, I want to thank you, everybody. And I hope that you have a wonderful day. From my heart, I appreciate every single minute that you spend with me in this webinar. I truly, from my heart, I hope that this webinar will help you to improve your practice and to provide a wonderful care to our most important, which is the reason that we are dentists, which is our patients. I really want to thank you, Air Techniques, for inviting me to give this webinar. And I want to thank you, Viva Learning, which is just amazing. This is, I don't know how many times I have been giving webinars to Air Techniques. So thank you so much, everybody, and have a wonderful rest of your day. Thank you.